This recording is open to public disclosure. Please do not disclose any private or confidential information. Guidelines for public feedback. This work group is not subject to the Open Public Meeting Act. Members of the public are welcome to attend and observe the SUD Intake Screening and Assessment SUDISA workgroup meetings. Meeting participation, including use of the chat, will be limited to workgroup members unless otherwise specified, i.e., guest participants, panelists, presenters, etc. If you are not a committee member and would like to provide a comment or question for the workgroup consideration, please email hcaesb5476 at hca.wa.gov, and the workgroup administrator will share your message with the workgroup. Sharing real quick. So today, I'm pulling up the agenda right now. All of you, I emailed the agenda. We did some disclaimers and guidelines. Oh yeah, 1 second. I'm gonna go ahead and share again. I think I should keep my share actually open. As always, I always share this at every SUDISA. It's always good. As most of you know, this is the SharePoint meeting materials and such, and how we get to our draft documents and everything is you click on Documents, SUDISA Recommendation Reports, and this is how you get to our SUDISA recommendations right now. And so I just like showing that at every meeting because I think it's good for us all to know. Next, going over so only heard back from, I presented in front of the WSADCP and AAP. I want to say the WS Washington State Association Deferred Court Prosecution. I'm not 100% sure what the DCP stands for. But I met with them. I got it right when I met with them too. And then I met with the AAP. So that's two associations I met with. And then I heard back from the AWHAP, Washington Health Plan, Association of Washington Health Plans and such. So I wanted to share with everybody what the associations had to say about each of them. There wasn't much, honestly, from each of the associations. From the WSA DCP, they only requested is there other language that could be utilized instead of level of care of assessment, because there could be a trip up with billing, and they're wondering could screener be used instead. We kind of talked to them a little bit about that, and so they asked more information about that. And then that's mostly what they talked about. The AAP, they talked a little bit more about recommendation. I want to say it's the educational campaign. So they talked a little bit about the whole social workers that can do assessments if it's within their scope. They brought up, so a social worker who works in a behavioral health agency who's been trained in ASAM diagnosing and everything like that can do an SUD assessment. Their thing is like, what is the real standard there? Where's the WAC requirement saying what knowledge and what is considered within their scope? And so they asked a lot of questions around that, and they brought up an idea of, would it be something that the group be interested in hearing about, more or less what about the HCA, or I don't know if this would be an entire another recommendation, but basically making it where people who are not SUDPs could get specific training around not just the ASAM, but diagnosing and other parts of how being an SUDP. They brought up an actual really old program. It used to be a program back in the day that probation officers used to be able to actually do SUD assessments. They would go through a specific course training, and they were able to do it. Found that really interesting. I've never heard of that before, and I thought that was interesting. But they were kind of wondering, with not just telling people like, hey, did you know a social worker, if they're within their scope and everything like that, is there any way that we could help support people who want to do assessments inside behavioral health agencies that are not SUDPs to get specific training so that they can conduct SUD assessments? And that's kind of like what the AAP talked to us about. So I'm gonna stop right there real quick and talk about the AAPs. Does anybody have any specific thing to talk about as far as what the AAPs recommended? Like for it, against it, good idea, it'd be too much, it's another recommendation, something like that, maybe.
This
Elizabeth, she gave me a thumbs up. Did you mean to do a thumbs up and you did the hand raise by accident? Yeah, no, yeah, we've all
Yes.
done that. Yep.
I think it's,
Yeah.
I mean, it's wonderful that somebody is volunteering to help the state get that information and training out to people, providers, you know?
Okay.
Is that what I
So,
heard?
well,
They want to help
they're
us
saying,
educate.
well, they want they would. I think what I got from the meeting, and even if anybody else was there who attended, you can speak now too. They more or less were thinking, is there a way the HCA could help provide training, like such as like what we're doing with ASAM right now. We're giving ASAM training. Could we give more training to folks about diagnosing and such like that, so they could do SUD assessments and be competent within that scope, doing it? So they're asking, could we do something similar to what we're doing with the ASAM and provide more training for people who are not SUDPs at BHA sites?
Right.
So can I read this, Teresa? Can I reframe? So they would be asking for training for clinicians. So in assessment and diagnostic core competencies.
Yes, for people who are not SUDPs.
So I mean, I think I just want to make sure folks understand the reason why we're able to do the ASAM training is because the legislator appropriated a lot of money.
Mm-hmm.
And so that's the only reason. So I just want to make sure we're clear about what the ask is, because we would have to have appropriated funds.
Nope. Yeah, no, Teresa. Yeah, and that's come. I wanted to bring it back to the work group and ask them, like, and I think you're pointing out a really good. I'm really curious if there were funds available, how many people who work at BHAs, if they offered, because we already offer the ASAM training, but if there was a training around diagnosing and other parts of being an SUDP, what the interest is like. Would there be a great interest? But then again, when people hear free training, sometimes they just, I sign up. So, I mean, I'm just wondering how much of the interest is out there for a social worker that works at BHA. They would want to do a training to learn how to do the assessment or diagnose. I mean, but it would definitely take some funding. Yeah.
This is Brandy. I just tell you, I would, be interested because we're moving towards having all of our all of our associates, master's level clinicians that are that now can diagnose. We're moving towards training them and having them complete the ASAM training as well as. So we're providing in-house training for them in hopes of getting easier access for people who want co-occurring services, or just for our walk-in assessments to be more easily completed, regardless of why somebody is walking in for an assessment. So we're moving towards that internally, regardless. If there was additional training, of course, we would participate and have our staff participate.
And Teresa brings up a good point of funding. We can make the recommendation, but then, like, is it going to happen? We don't know. So I just like to thank you for your comment, Brandy. I super appreciate it. Is there anybody else in the work group that feels some type of, like, how would you feel about more training for non-SUDPs?
I am a little concerned. Sorry, I am just a little concerned when I hear that, because it's like there's so many people who want to be able to do the assessments, and I appreciate that, and I know there's a big need, but how does that comply with, we're supposed to follow the ASAM standard, and in the ASAM, it says you have to be certified to be able to do an assessment. You have to be SUDP, SUDT, if it's a counselor becoming an SUDP, that's fine, but you can't just have it like a probation officer do an assessment.
Well, so that was just an example that was used years ago. I'm not proposing a probation officer. This is for this is right now. The state plan does allow certain credential folks to do an SUD assessment if they're at a BHA and they've been trained in ASAM and and it's within their scope. And so I mean, like, what this would do is offer more training to non-SUDPs so that they could do an SUD assessment along. It's much like the ASAM training. Also, too, would that be an entirely new recommendation, David?
Oh, I just had a quick question. Isn't it within, this is my ignorance, the scope of like a LICSW to already diagnose SUD? Isn't that part of their licensing and training?
This is Eliza. Kelly, do you mind if I jump in?
Yeah, go ahead and jump in, Eliza. Yeah.
Yeah, so you're correct. It diagnosis is within their scope of practice, basically utilizing the DSM 5, and that's why we aligned with DOH to expand it, and why we expanded also provider types within our state plan for certain services. But while it is within their scope of practice to diagnose, they have to have the training to be able to do an ASAM assessment in order to appropriately diagnose and discern what level of care is needed, right? So, and there's very few counselors. I'm one of the rare that is duly licensed as an SUDP and LMHC. And so I think the intention is while they can diagnose, they need to have it within their scope of practice and training to be able to do ASAM assessments and really know the levels of care that they are offering. And it's not necessarily automatically within their scope of practice to render ASAM assessments, even though they can diagnose, if that helps.
Yeah, that helps me. That makes sense. And I was interpreting this as something they had to do in addition to the ASAM training. Doing the ASAM training and being confident in that makes sense to me, because not all are going to have that experience. But having to do an additional training on how to make a diagnosis of a substance use disorder to someone who's already licensed to do that seems a little excessive. Making it available to people who want more makes sense, but it just seems like a double certification for something. But the ASAM assessment, I totally understand.
Yeah, and I do think that this is also going to be like agency specific. I mean, a lot of agencies may want you to come with clinical experience within the SUD world of diagnosing and levels of care, right? So I think that it's going to be dependent on what agency policies are and what they're expecting for their clinicians. So I think we have, some of this recommendation, it makes a lot of sense, but then there's also going to be a separate element to it.
Also, too, the AAP just made this recommendation. Doesn't mean we have to necessarily say we have to put it in our plan in our recommendation. At the end of the day, like so much like Brandy said, she said that her agency has decided that we're going to go ahead and make sure our people are competent, trained within scope, and everything like that. That could be an agency thing that happens. The agency has to, kind of invest in that to make it work. That's just a suggestion for me. I'm just saying.
Yeah, I just think it's really important. This Teresa, that's why I asked for clarification, because we are doing the ASAM training, but I think what I was hearing was a recommendation for specific training that would focus more on core competencies in the clinical assessment and use of the DSM-5 related to SUD disorders and diagnostics. That's what I was hearing. And, I don't know, guys. I mean, I'm not sure like where all the master's programs are at for SUD. You know, some of them offer tracks and some of them don't. And so I guess I'm a little bit in the middle of the fence here because I'm not sure what kind of training is being offered at that master's level across our state.
This is Brandy. Based on the interns that we receive through coursework, we have very few, at least in Southwest Washington, where we receive master's level interns. There are very few of them receive any education on substance use disorders unless they've specifically taken an add-on course, or there is one college locally that actually does that. If they're not on a master's level substance use track specifically, other behavioral health master's levels do very little on substance use that I'm aware of locally.
This is Eliza too, and I will say, like, when you're looking at credentials like LMHCs or LICSWs and the education requirements, there's not specifics on like addiction, right? That's not one of the educational requirements for getting your LMHC or your LMFT, etc. So that's just something to kind of keep in mind as well.
So for this language from the AAP, and remember, it was just simply a suggestion from them because they want to make sure there's good, competent people that are doing the assessments and everything like that. That's what I got from them, and they were just talking about trainings and stuff. And yeah, I like everything I've heard so far from everybody. I think it's a good point, and I'm just curious about where do we want to land, or do we want to kind of think about it? And I can send out an email, and everybody can kind of sit with it for a little bit. And I can send an email talking about what the AAP said, and then see what you guys say in response to the email, or you know, because this is a lot to process and it's something to think about. I don't know if we should do it right here in the meeting where we have an hour left to make the decision, or if we want to think about it for a day and come back to it.
This is Brandy. I support adding the recommendation if it's not going to change. So, support adding that as part of the educational campaign if it's not going to change the overall recommendation. And I also like in feedback from external parties that this has been presented to or asked about. I think that's helpful in just collaboration and accepting changes and things like, when you ask for feedback, if you can include it, it's really helpful.
Yeah, thank you, Brandy. I appreciate the comment. Yeah, Eliza, I liked what you put in the chat. Hey, Eliza, do you want to expand on that a little bit?
Well, I think I was just offering like an additional phrasing, right? Like I think we just need to be clear, like what's what's in scope of practice is being able to diagnose based on the criteria that's within the DSM-5, and like those skills are a part of like LMHCs and whatnot, but it's not necessarily a given that someone knows how to assess that diagnosis and apply it to ASAM for levels of care. And that's like kind of the gap. So it's in scope of practice, but you're not necessarily trained to apply it, if that makes sense. It's kind of a little nuance there.
Yep, I agree. Angela, I think I saw your hand up earlier and then it went down. Angela, go ahead.
Yeah, hi. So I'm also a LICSW, and I just was agreeing with many of the things that people are already saying, but I think I'm hesitant to say that we should add specific language saying we need further training. I think, across the board, there's a lack of behavioral health providers in the community. And, as a social worker, correct, like coming right out of graduation, you might not have all the skills you need. And so if you are wanting to work in the SUD field, I would hope that those people are going to get their education, try and take classes, get that ASAM certification. But I'm hesitant to add in language that we would then need further training on specific assessments, because we all know, when we come out of school, you always will need on-the-job training, and that's just going to come inherently with experience. And so I just think, as we're talking about, increasing the workforce, I would just be hesitant to add more language that master's level social workers who are able to diagnose and also would get the ASAM certification would then need more training. It just seems like a barrier to folks needing to have bodies to do the work, if that makes sense.
No, it does, Angela. And I'm just going to read Teresa's comment, then I'm going to go to you, David. Could the recommendation be just to offer training options, but not that it is required in order to? And I could see that too. David?
Yeah, I'll just second exactly what Angela and Teresa just said. I was just thinking the risks and benefits of adding another requirement are obviously the benefit is that there's more assurance of a certain level of competency, but there's a real risk that less people do it. And if it's something that is required for someone to access payment for their medical care, and we have less people doing it, we know less people get care. So that is a risk that's going to happen if the more additional small requirements that get put up for people who we think already have an independent license, have completed a master's program, completed a license and exam, and I trust most of them can assess their ability and what they need more training in and what they don't at that level of, training. Anyways. I mean, that's how it works. Just thinking of me as a physician, my scope of practice technically is much broader than anything I would actually do. We rely partly on ourselves to know what we are actually comfortable doing and when we need more training.
Thank you, David. Appreciate your comment. Brandy?
Yeah, I think for whether we chose to put it in or not, I'm comfortable either way. I think the fact that this year was a change, and so I can only speak from my experience in my current behavioral health agency or ones that I've worked in. It's a pretty significant change to allow mental health associates, not licensed practitioners, but people pursuing licensure in a BHA to provide substance use services. Historically, that's only been done by SUDPs and SUDPTs. And so because this is a very new recommendation or a very new change in our state, I see it as, part of a educational campaign, kind of like ASAM, even though ASAM is going to be required, that it's more of a support network to the behavioral health agencies to get people trained so that they can access. I would never want to recommend it being required or turning it into some sort of requirement or mandating mental health practitioners to have it. So I would support it as a support and recommendation for support, not a requirement.
Okay, thank you, Brandy. Appreciate that. Elizabeth, you did the raise hand thumb thing again. I feel it. I've done it a few times. So right now, what I did was I added Teresa's comment under this part right here. so that I could be looked at. Is there anybody that's in strong disagreement of what Teresa um had put in the chat box? There's somebody that's like, no, I don't think we should have this, or wants to put something in the chat for something else to think about. Anybody have any disagreements with me? Just put in the comment here, and then we can look at what this might be able to be looked as, just adding training options. And this is a recommendation will go to the legislator, and as far as money goes, I mean, they're going to be looking at that too. So, I mean, but no one, I'm not seeing anybody disagreeing or raise their hands or anything in the chat.
I think, and this is Teresa, I think what we're all kind of I'm hearing agreement that we want to support the field. We want to offer pathways to support providers and clinicians, but we don't want to create barriers. And so, I think it's just, really being clear that it would be a recommendation to basically offer training pathways and options, but that it's not a requirement. We're not going to track this in a way where it's like, oh, you can't do an assessment unless you've done this training. So I think that's what I'm hearing from the group, right? Like, just we don't want to create additional hoops or barriers. We're not in a place to do that. Okay, so I think we're all on the same sheet of music. Thank you.
Thank you, Teresa. Appreciate that. All right, so moving on to the next association. This will be the last association which I heard from, was the Association Washington Health Plan Association. And in each of the recommendations, well, actually only really two of them, they kind of spoke on recommendation 1 and 2. It spoke a little about ASAM, but I don't think it was clear to them that we were just giving them information about ASAM, that we weren't. They gave us something, and I don't think it pertains to us really, but I'm going to go ahead and share what they gave us. And so when I shared out to the associations, I shared them a background of SUDISA, the ASAM 4th edition criteria, how, the level of care assessment is going to be coming out. This is kind of a Word document for the slideshow I've been showing them. They made a suggestion about ASAM. None of our recommendations are about the suggestion of ASAM, because we just said that there's going to be training and such. But this is what they had to say about recommendation 1 and recommendation 2. AWHP comments: given 1, finite funds available to improve healthcare in Washington; 2, high prevalence of coexisting mental health conditions in those with SUD; and 3, overwhelming evidence that individuals with SUD benefit more from integrated whole person treatment versus segmented SUD only treatment programs, would be prioritizing increasing rates in quality incentives for those providers who offer treatment for SUD and mental health concurrently, utilizing staff trained in the full scope of behavioral health conditions. This approach is further supported by ASAM 4th edition, which describes typically co-occurring, capable, expected at each ASAM level of care. Hey, Eliza, I know I'm kind of put you on the spot. What do you infer that to kind of mean to you?
To be honest, I was responding to a comment made in the chat.
It's totally okay.
So
I saw you.
Do you want to bring it? Yeah. Do you want to bring it back around for me, and I can answer for you?
Yeah, I am gonna read it again, guys, because it does seem like it's a little bit of a little, just a lot. Given 1, finite funds available, and this is for increasing the Medicaid fee schedule reimbursement rates. Finite funds available to improve healthcare in Washington. 2, high prevalence of coexisting mental health conditions in those with SUD. And 3, overwhelming evidence that individuals with SUD benefit more from integrated whole person treatment versus segmented SUD only treatment programs, would prioritize increasing rates and quality incentives for those providers who offer treatment for SUD and mental health concurrently, utilizing staff trained in the full scope of behavioral health conditions. This approach is further supported by ASAM 4th edition, which describes swiftly co-occurring, capable, expected at each ASAM level of care. They didn't kind of say they were in favor of our recommendation as much as, I mean, I guess it's a comment. I mean, yep, Michelle.
I could be misreading it or misinterpreting it, but it sounds like they are just like suggesting a tweak about the language so that it's instead of um making a change that's specific to reimbursement for substance use disorder treatment only, that we would increase reimbursement for folks providing treatment for co-occurring, that to just widen it a little bit. So because of the rate of like co-occurringness, for lack of a better word, between substance use disorder and mental health, and the holistic nature of like the treatments when you are looking at like more of the integrated whole person treatment, right? So I think that's what they're saying there is just, rather than using language that limits it to SUD treatment specifically, can we broaden it a little bit to be inclusive of the like co-occurring, and to benefit people that are providing integrated whole person treatment, rather than the more kind of targeted SUD treatment. So I don't know how to change the language specifically for that, but that's what I think they're saying in that feedback, and that doesn't that's not a big overhaul of the recommendation. It's just a small adjustment to my mind.
Yeah, because I mean, right now the recommendation reads for behavioral health services, so the behavioral health providers, facilities, organizing providers. I mean, we say behavioral health services. That's pretty broad to me. That's like,
Potentially, it can say something like organizations providing substance use disorder and co-occurring treatment, or substance use disorder treatment as part of like their entire milieu of services or something like that. I think would address the comment that was provided. Just so to their point, we're not like further siloing SUD treatment.
is there anybody that's, hey, Sarah, would you mind putting what you just said in the chat? I also have transcript on my side, so I have that. Okay. With what Sarah just said, with just broadening it a little bit in the recommendation, is there anybody that's against that? That thinks that like that's a bad idea? Wants to speak on it? And okay, can I see some thumbs up that are okay with what Sarah added with the language? Just not having it so narrowed down. They could be a little broader, so we could, for others, co-current cable stuff. All right, I'm seeing a lot of thumbs up. Amy, did you mean to do thumbs up and you did the hand? Yep.
Yep.
Hey, if you don't do it at least once during the meeting, you're not doing it right.
I agree.
Yep. Okay. All right. I need to go ahead and this is for recommendation 1. One second, guys. Just got to do this. There we go. Oh, there it is. Okay. Okay. Got it. All right. Next. What recommendation 2, what they had to say about, I really like this one. I thought this one was a pretty good one, what they recommended. AWHP comments, consider emphasizing real provider experience and feedback from those who prescribe MOUD, MAUD in settings outside of specialized SUD, such as primary care, OB, GYN, mental health, psychiatry. Providers frequently report great satisfaction offering life-saving medication to patients and short learning period to reaching confidence in prescribing. So I think what they want to add is gaining real provider experience. Is anybody against that? Like adding that as part of the educational campaign, that we would gain provider experience? I mean, that might be part of the process anyway, but we can emphasize that within the recommendation. All right, thumbs up, thumbs up. Yep. I didn't think anybody was really. Yeah, that's what I suspected. Okay, I'll be adding this whole comment into the draft page now. This is for recommendation 2. And comment. Boom. Got it. Okay. I do want to bring it up just because I was going to make it last just to make sure, but I didn't know how much discussion we were going to have on the other items. But just to bring it up real quick, they did mention this part with the ASAM 4th edition. I don't think this would go anywhere in our recommendations, but I want to make sure to present it to the group so everybody has it. So I'm just going to read it out loud, and if there's any comments, just let me know. We were just giving them a background on ASAM 4th edition when we gave them this, and they decided to make a comment under it. AWHP comments would suggest adding to ASAM 4th edition section. New edition of ASAM published in December 2023 and already being utilized in many states underlines the importance of individualized treatment, courses based on individual patient/client need. This includes length of stay, duration of treatment, and a specific program. There should no longer be fixed length SUD treat programs, 30 days, 90 days, etc., or standardized content for all patients in a given program. But instead, the programming should be tailored to each person, then adjusted frequently during treatment based on their progress. This kind of just reads to me as literally like a comment on what they're saying. I don't think this really pertains to us, but is there anybody else that feels any different about that comment being read?
Well, what's ironic about this comment is this is all true for true with ASAM 3rd edition, right? Like, I mean, if you're properly using ASAM and being person-centered, it's not fixed programming.
Yeah,
I agree with Teresa. Yeah, I don't think it hurts though to like have that because there still is like, oh man, I don't know. There's still comments being made about it, about like people are wanting 30-day treatments and it not being personalized. But sorry, Teresa, if I cut you off?
Oh, you're fine. I'm just commenting on the comment.
Mm-hmm.
Like, well, the ASAM 3 is,
Yeah, and I think that's gotten lost, honestly. It seems to have gotten lost sometimes in conversations about treatment, especially when we've been talking about like legislation regarding authorizations and whatnot. That's come up quite a bit.
Do we want this added to the report for any reason, or noted somewhere, or I'm just curious if I should do anything with this specific comment. Because I think Brianna.
I see Alicia said no.
I don't think it needs to be added either. This is Brandy.
Yeah. I don't. I mean, if it was added, just so you guys know, if for some reason it did get added, like because we want to add comments from established associations, it would probably be like that on the report. It would say from the associations, this is what was said, and so I mean,
it should be. I agree that it should be followed already. I just wonder. I mean, if it was added, I don't think it would be like the new edition. I just would think, ASAM, and then like reiterate that comment if it were to be implemented up top. What's interesting to me is AWIP is seeming to think that it needs to be like reiterated and or at least put out there. So that's interesting to me that and then again in conversations, I just wonder what the harm is, I guess, in putting it up in the ASAM section, but if it was altered to not say 4th edition, right? it would just be like a reiteration of ASAM.
You know, I'm just thinking if a reiteration, would anybody be against that? Because that's a good point. If AWIP is saying this, is a reiteration just making sure it wouldn't be added to any recommendations. We have a certain part of the report where we talk about the ASAM fourth edition and how we have the ASAM level of care now and how that's going to shorten the assessment. We have like a little part in the report where it talks about this. I think that this comment could be added from the association that says that, you know, and say third edition. Would anybody be against that? Adding it just to the report for that reason?
I think, and often, like maybe some of the association comments can be added in an appendix or something like that, just so
Yes.
it's not necessarily cluttering up the body of the report. But yeah, I think we need to figure out a little bit more exactly how it will be organized, as far as kind of how we would incorporate that comment. But it does sound like, to everybody's point, that it's just reiterating that the ASAM should be followed. So
No. Thank you, Sarah. David?
Yeah, I'm just thinking maybe some brief statement on, I don't know how to phrase it, but like in the past, the individualized treatment recommendations of ASAM have not always been adhered to, and we strongly recommend following the individualizing treatment component or something like that. That just broadens it to that specific element, not the length of stay specifically, I guess, if we're going to do something. But to me, it's the individualization in general that's the important part.
Thank
I
you,
like
David.
that. I like
Oh,
that
go ahead.
idea. And I just want to also offer like or remind that like, when because again, this has been coming up in legislation, that even if like a certain amount of time is authorized per se, like that it still needs to be individualized like assessment throughout that time. It doesn't just mean like, hey, they automatically get to be here for that amount of time. Like clinically to be, we should be assessing as clinicians kind of throughout that time period, not just think of it as a fixed length of stay just because you have an authorization for that time. Does that make sense?
Thank you, Eliza. I appreciate the comment. All right. Well, that kind of takes us through. And if any of you were wondering, I don't know if I showed this to you guys all before, but these are all the associations. Um, Probably like one missing, but I think this is pretty much all of them. This is all the associations I reached out to. If you belong to one of these associations and you're like on a board or something like that, and you didn't hear nothing about SUDISA, please let me know. I will re-email that association, and I can ask them for more comments if needed. Also, too, maybe with time constraints, that maybe they felt like they couldn't get something done. That's also a possibility, maybe. But I do have real quick designated crisis responders. They understand they're past the deadline to respond, but they still said they would like to if they're able to. And I told them they can still respond. I just don't know if we will be able to add anything they say. And they said that they're going to write up something for us to give to us. So I'm kind of curious on what they might say, but they said they're going to move forward on that. So okay, so next I pull up the report. Okay. I'm going to be spending because with HCA folks' comments, I might be mentioning some of them, but we have like over 33 comments, and I'm going to be going through them. Oh, Eliza?
Just a really quick question. When you get the DCR stuff, are you going to be sharing that with the group? The reason I ask is because DCRs may offer a perspective of the detention aspect, and what barriers they experience. And that could be very just helpful when they're looking at these recommendations from that perspective.
I am going to share it with the group. They said they're going to get it to me by Friday, so I'm going to share it at the next meeting for that exact reason. I just, I didn't really tell them this that much. That they're like, "Is it okay to just keep doing it?" I'm like, "Yeah, it is. Just go ahead and send it to us." But I'm letting all of you guys know that even though I might be able to share it, and they might have a really good, unique experience with the timeline where it's at. Don't know if we're going to be able to change anything depending on where we're at when I get their recommendations. And so, yeah, I want to share that with the group so you guys can hear that perspective. Actually, I think our person who's usually DCR, she's been here for every group except for this one, I think. There's no other DCR in the call right now, right? Yeah. Okay. She got on the meeting beforehand and let me know she was going to miss. I'm pretty sure she's DCR. So, but I didn't think we had any other DCRs. But yeah, I think the unique perspective the DCRs offer for involuntary holds is very unique and is very much needed. So yeah. All right. Has everybody taken a gander at the report so far? This is a very rough draft. It even says December 1st, 2024. So it's a very rough draft right now. So all right, I'm gonna go through it. You go to table of table of contents, and it's right here. Executive summary, recommendations, conclusion, additional recommendations, appendix A, B, C, and D. Just so everybody knows, this is a very rough draft, and so we have a lot of comments from HCA staff, people from the work group. I'm really glad to see that I have quite a few comments from the work group, and so I'm gonna go ahead and go through this. The executive summary, supportive initiatives. We do have some cleaning up that's going to happen there. I'm going to get with Brianna after this. Actually, the steering committee is meeting tomorrow afternoon, so we're also going to spend some time cleaning this up during the steering committee and adding verbiage and language and such. So let's go to. I'm going to go through the comments real quick that I saw. Alicia, you had put, "Are financial incentives sustainable? Where would the funding come from, and how would it be determined? Do not see this as a viable option." Um, so everybody knows. I don't know if I shared this in the last meeting, or I don't know if I did. I think I had my meeting afterwards. I met with a few people in the HCA about the dedicated cannabis fund, and it does look like that the dedicated cannabis fund, that there's no reason why we can't go to the legislature with our recommendations and ask for money from the dedicated cannabis fund. There's like I talked to a few people in the HCA and they basically said that it is low requirements. So, but it's a little bit of a fight to get the money in the first place. But once you get it, it's pretty much established. And so, some of the recommendations could be funneled through with the dedicated cannabis fund. So I'm just going to add in the comments DCA for right now. Oh, no, wrong comment. Oh, sorry. But yeah, so I mean, I don't know if I mentioned that in the last. I don't think I did mention. I think I had my meeting after the last meeting. So I just want to make sure everybody knows about that, about the dedicated cannabis fund. It was very cool to hear about, by the way. Oh, I lost a comment for there for a second. Oh, it keeps doing that to me. That's really weird. I hit the comment and it sends me back down. But okay, I'll write it on my own, I guess. So next comment. Let's see here. Those are remarks about wording and verbiage and stuff. So guys, I'm just letting you know I'm looking for content, mostly about from the work group. Okay. Well, the next comment I have is under recommendation 4. So actually, this brings me up to the topic of choice. I'm really glad this came up now. So as I've been presenting, I'm gonna get to it. I just want to make sure I'm on the. Okay, yeah, I was. Okay, Appendix D. So as I've been going through and presenting to all the two associations, to the monthly tribal meeting, and such. Just by mention, we're supposed to also be hearing from the tribe by at a certain date too, about where they might fit in some recommendations as well. But in this recommendation 4, when I've like talked about it, it's very unclear to me what this recommendation is meant to do. And so I just want to know if there's someone from the work group that kind of wants to, if you think that like, hey, this could clarify what this recommendation is for. And so this recommendation, what we have is expanding remote access to pathway to receiving SUD assessments, i.e., e.g. via phone calls, via phone or video calls. And I had made the comment that I talked to the DOH about possible like phone calls in specific situations where it's needed. Like Brandy had mentioned, she had mentioned like, what about sex offenders who live in rural areas but can't access the internet? Situations like that. And the DOH basically says that they're going to have rulemaking in 2025 for BHAs, and that's something that can be discussed. Where we can just at the rulemaking you can discuss like in certain situations could we allow phone assessments, for those particular situations. But right now I'm kind of unclear on what the work group wants HCA to say to the legislator about this recommendation. If there's anybody that wants to speak on that now, that'd be great to hear from you.
This is Amy. I was reading, it's actually already in the WACs that they can do audio calls, but they have to have an established relationship with the patient to be able to do audio calls for further care. But I think to Eliza's point that it's the healthcare authority is the one that made that no, we can't do that because they don't believe it's good care basically to do only audio calls, but it's already covered in a WAC that it can be done, just not the initiation. Our new patients.
Yeah, and I think, Kelly, I think I added on the other. So my comments, unfortunately, I couldn't edit and get it into the draft that was in the SharePoint. So it's in another. Yeah. So I added a bunch about the expectation and why that the added assessment piece is going to be really challenging too. It doesn't meet the safe and effective care that was what we were tasked with, right?
Yeah, I think you have it right here, Eliza. Is this what you added?
Probably.
Yeah.
No, it was up by that phone assessment piece.
Up the top?
No.
Recommendation 4.
Sorry. I know that I put a comment about safe and effective care.
You did.
By that, and why there was a limitation, but nonetheless.
Yeah. So I mean, so it doesn't seem like the phone. And don't get me wrong, can we technically still make a recommendation for phone assessments? The work group can do that. From hearing from DOH and folks within inside the HCA and DOH and I just I don't think it would move very far in our recommendation, in my opinion. Not saying it couldn't.
So my concern is we want to be realistic about what we're presenting, right? Because there's a lot of legislation happening and moving, and then there's a lot of eyes kind of that may be on this, right? So if we're saying as a work group, which is professionals, we're all professionals from different areas, and they're saying, well, you all as a work group full of all different professionals think that this should be a recommendation, that might be conflicting, because what I'm offering is that as a state agency, we're not looking to allow assessments over the phone because of the elements of a mental status, and especially for SUD, looking at some health related things like possible withdrawal symptoms and whatnot. It cannot meet the standard federally for safe and effective care. And I don't know a way around that. You know what I mean? So I think I'm a little hesitant, honestly, but I see, and that's just kind of my thought on that.
Thank you so much, Eliza. I'm going to add something just real quick. I'm going to go to you, David. Being a provider, I remember when we first went to telehealth, like not first, but when the pandemic happened and a lot of people went to telehealth. And one of the big things is like, when we assess somebody, we look at like, their eyes, their body language, their movement. Some people could be using drugs right before the assessment, and sometimes you can't really tell that on Zoom or on the camera even. And so, how come in-person assessments sometimes are good, but it's also about getting people care, and I understand that too. So, I mean, both perspectives for sure.
It also goes against our statute. Just want to put that out there. We'd have to alter our current statute and WACs and whatnot.
Thank you, Eliza. David?
Sorry. Yeah, I think I totally agree with what you were saying, Kelly. Ideally, I think we all pretty much would agree in person, you get a better assessment, and also it can be a barrier. I don't understand. So for medical care, they've made it clear that we can establish care and treatment through audio only telehealth services. So I don't know if those bills are the same bill. I don't know.
It is 5481. Okay. Yeah, 5481. It like last year it actually passed, and it had differences for behavioral health and physical health between 2 years and 3 years, and now it's 3 years all the way around. Someone would have had to establish care face to face. Or excuse me, not face to face. That's when you can do video in person, like an in person. And so that is currently what is outlined in the overarching agency policy for telemedicine here at HCA.
Got it. And I obviously wasn't involved in those discussions. I still think it makes sense to recommend it. I mean, it seems wild to me that I could treat someone's pneumonia over the phone based on DOH regulations, but you couldn't do an assessment that's mainly based on history. I wasn't involved in those discussions, but it seems weird that physical health, which often relies on physical exams.
Physical health has a lot of actual limitations on audio only. We have a code list to kind of demonstrate that for audio only. So there's certain things that they really cannot do over the phone, and that's kind of outlined via our physician's guide, at least for what HCA has established for Medicaid. And that list can be provided. Actually, it's in one of the links, but there is some restrictions, but it also is a different kind of assessment for physical health. So we had to take that into consideration as well, and whatnot, and what they're trying to do. So some definite nuances there that you're pointing out.
I like this conversation that's happening though. This is great. I think this is a good conversation, just saying, guys. So other than even this piece saying something about phone assessment, what else is this recommendation really saying?
My understanding, Kelly, is that the purpose of this as well is to increase availability of video assessments so that people can access virtual assessments if that is more accessible and available to them than walk-in appointments. So just expanding the capacity to meet virtually, even if that does, have to mean audio and video, which I think it does for assessments.
And I would say to what Sarah's talking, to her point, yes. And I was on a provider call, and there was a couple agencies who were trying to stand up and do. Prosperity Wellness Center just contacted me because they heard about our fourth recommendation, and they were like, "Is there any kind of like stuff you can offer us to really like maximize telehealth?" Also, right now, as far as I know, and anybody from the ACA, please correct me, and if there's a website, we can put it in the chat. But there's no real way to determine what agencies are offering telehealth and what agencies are not. You have to go on their individual website and you have to figure out whether or not they're offering telehealth. It's not in the Green Book. And I've talked to DOH about this. They're not going to put telehealth stuff on the Green Book at all. And so I don't know of any website. The Washington Recovery Helpline doesn't have, I think the MAU the Mound one tracker within Washington Recovery Helpline offers something where when you click on an agency, it will tell you if it's telehealth or not. But other than that, I don't think. Yeah, and that's my whole point. I'm about to get to, Eliza. Yes, to that point is that maybe this recommendation is about more about us helping agencies uh, become more telehealth capable. If they reach out, then we can do something to help them. I'm just kind of want to hear some thoughts from some people on that.
I think that I just want to offer, I think there is still a kind of a misunderstanding out there, and that's why I put the education piece and really help agencies understand that it is allowable. The restrictions, especially for face-to-face, are like few and far between, because face-to-face is video. And then of course the audio only list, like there are a lot of options that I think are kind of unknown. So that's kind of where and yeah, that's a good, and seeing this SUDOP and IOP. Yes, I will put that in the chat, the link.
So two things I wouldn't mind bringing up is that do we want to fold this recommendation in with educational campaigns where we basically do an educational campaign on telehealth, where we go out and talk to people about telehealth and agencies about how they can make their agencies, better with telehealth. That's just one of my suggestions. Also, too, one of my others. Oh, Teresa, Are you? I just see you coming off mic, so I just don't know.
I guess there's a lot of things going on here.
Yeah.
And I think I might be a little lost. I just want to point out that there's the Behavioral Health Institute, BHI Institute, does a lot of free trainings around telehealth, and they're recorded. And I think too, I think what I'm hearing, it might be good to have a telehealth section instead of folding it in, because I feel like it could maybe get lost, and telehealth really is nuanced. And I guess I'm hearing stuff in the discussion that's not what I'm necessarily seeing on the screen, right? I'm seeing, like, wanting to make sure that providers are aware of the do's and don'ts for what's allowed. I'm hearing a desire to expand access to telehealth, which is the real-time audio-visual services. And then I'm hearing kind of different opinions around the phone audio only. So I'm hearing like three buckets, but I'm only seeing one bucket on the screen, which is phone.
Yeah, agreed. So I yeah, I think we could. I think that yeah, I want to know what to write next. Teresa, do you think that, because I think I haven't heard nobody disagree that there should be more education and all, that DBH thing. I've never heard of that place. I've been in the field for 12 years. I've never heard anything about more training for services. I mean, um, I think that's a great thing to put out to people, to let them know about that more and more. But you are right. There's only the only thing that's really on here that's really something is like the phone thing.
And real quick on the phone thing, I mean, I don't know. I mean, I think that's the conundrum here, because we have federal requirements, we also have the statute. And I want to say that the original charter of this work, I think we tried to make sure we scoped it so that we weren't recommending things that were like against federal law or against statute, right? And I think if we're gonna expand phone only, audio only, it probably would entail legislative change with the bill that Eliza mentioned.
The 5481. Yeah.
Yeah. I think based on what I've heard.
And also too, like, I'm scrolling down and I remember, Eliza, you worked on this recommendation. You had a big bulk of a section like right here. And I think this is the stuff that kind of needs to be moved up to the forefront of the recommendation. You know, support and encourage SUD treatment agencies to update policy and procedures regarding what is allowable for SUD telehealth. I mean, my main question is, if you're a treatment agency right now, is there any reason why you're not offering a telehealth service as even an option? Like, and there might be several reasons why an agency might do it. For, I mean, not you know, if you're in a rural area, maybe there's a reason behind you wouldn't do it, but I think there'd be more of a reason. But I think this stuff right here, HCA to support, encourage SUD treatment agencies to update policy and procedures, HCA to provide education on difference between audio only and telemedicine based services, offer HCA support on what is allowable versus what not allowable. Yeah. And so, I mean, I think collaborate with the DOH regarding adding requirements surrounding providing telehealth, telemedicine, either a plan on how it's provided or indicating they do not provide as part of their license agreement. You know, I think this stuff is kind of like, this is the kind of what the recommendation more should be about, in my opinion. But that's just my opinion. So I just want to really hear from the work group on what they're thinking.
Is that legislative action or is that HCA action that we could be doing? Or are you asking for funding to support this?
That is a good question, Amy. Eliza, we already have a FQ, correct me if I'm wrong, FQHC, I think it is, for telehealth, right?
What do you mean an FQHC for telehealth?
I can't remember if it's called FQ. Remember when we were in the AAP with the AAP and we mentioned somebody who was mentioning stuff about telehealth, and you were like, hey, you can reach out to this person, and you had mentioned a person about telehealth. For the
Well,
HCA.
yeah, so Jody Kunkel is in a different division. She tends to be for our telehealth. I mean, any questions we really encourage to go through our mailbox system, which we can provide that link, and then tag it, and then it gets appropriated to the correct subject matter expert, which will likely be myself for the behavioral health side, and then Jody Kunkel's kind of the overarching agency policy and physical health side. If that's what you're referencing.
No, I can't. I think it was another person. I can't remember. I'll look back at my notes.
Are you talking about for FQHCs?
I think so.
Specifically, that's Michaela.
Okay.
Snook and her team. So kind of differences there, yeah.
I guess what I'm trying to ask is there a current? Because Amy brings up a really good question. Is there a current HCA person? Where if an agency wants to know more about telehealth, and is there like one person they can go to, or they're going to have to go to several different people within HCA?
So HCA, it's myself for behavioral health and Jody Kunkel.
Gotcha. Okay.
Yep.
So back to Amy's question, that is a good question. So if this is kind of more or less the recommendation right here, this stuff that is mentioning all this kind of stuff right here, if this is kind of more or less the recommendation we're going for, would this be something HCA does or something HCA recommends funding for?
I think if we're going to do a larger push for like an educational campaign specific to telehealth, we would need to request specific appropriations and funding from the legislature to be able to roll that out.
Okay.
Because we do have experts embedded in the healthcare authority, but that doesn't mean that, we could roll out kind of such a widespread educational campaign on telehealth.
Okay. So that's good. I mean, that's good stuff for us to know because that does make a huge difference. So So is anybody against like what this is kind of the spirit of this is that we're going to help agencies become more telehealth capable and be more widespread so that more people can be serviced faster and quicker?
I think that makes sense. I think there's an important question in the chat that distinguishes between treatment of substance use or substance use disorder within medical settings versus behavioral health settings, and the difference between being able to provide audio only to start medical treatment for substance use disorder versus in a behavioral health setting. So that might require a little bit of additional discussion here, just to ensure that that is also fleshed out within this recommendation. I'm looking specifically at Dr. Sapienza's comment. So I think that what Eliza was saying earlier is that to provide a full ASAM assessment and recommend a level of care, right? You're looking for withdrawal symptoms and things that you need to have the patient in front of you to safely be able to recommend engagement in a specific level of care and assess for withdrawal and things like that. But maybe Dr. Sapienza is pointing to like an outpatient medical setting and starting someone on buprenorphine, for example. So I just think that's an important distinction to discuss before we move on from the telehealth recommendation.
This is
Thanks.
obviously a bigger question. It's really confusing to me based on what I know my scope of practice is via audio only. Because it's a bigger question because it's odd to me that the license of a physician who would normally do a more intensive physical exam can make that assessment over the phone on whether they're going to do that exam, and then someone who's less experienced doing a physical exam has to be able to do the physical exam. It's just confusing to me, but I know this isn't the place. So.
We still appreciate your comments, though, Doctor, for sure. It's something definitely to have a conversation about, and I'm appreciative of your comments for sure.
I think too, just for this group to know that, I mean, the whole telehealth thing, I mean, we had a lot of telehealth policies prior to COVID, and then it just blew the roof off of it, right? And then there's a telehealth collaborative in our state that drives a lot of legislation. So I don't know. What I'm trying to say is that just to provide validation for the confusion, because I think it's been such a, I mean, we've had to move so quickly. I mean, in some ways it was a good thing, right, with COVID, but it really has been an area in our field that has had to move really quickly. And then, phone only and all the nuances. So I don't know. I still think it's evolving. And the data is also evolving. If you get on national calls, you look at the data of what's effective with telehealth, it's all over the board.
And for Teresa, for that Washington State Telehealth Collaborative, is that part of the Washington State Hospital Association, or are they the ones that do the forefront of the Washington State Telehealth Collaborative?
It's bigger than that.
Okay.
Yeah.
It just, when I Googled it, that's the thing that came up was Washington State Hospital Association. Okay. It looks like a whole bunch of people. Oh yeah. Okay. I found that one. Okay. I was just looking to see if there was something I could put in for the Northwest Regional Telehealth Resource Center. Okay.
And
all right.
Yeah, and I'm not asking you to add that information to this report. I'm just providing context to the group just with telehealth in general.
No, I was just gonna put the collaborative in the chat. That's all.
Oh, okay.
Yeah, so people could have access to learning more about what is the state, because I've never heard of that before, and I think that's amazing. So yeah, and I think Elizabeth actually Myers put in the website I found, which was Northwest Regional Telehealth Resource Center, which talks about it. All right, so I'm not hearing no disagreement that this right here, what I have scanned, is more or less the spirit and purpose of this recommendation is that we're going to help support agencies become more telehealth capable. I didn't hear no disagreement for that. Okay. I will get with Brianna after this, and then when the steering committee and all of us meet, we're also going to be making changes to this. So we'll probably be moving this portion more up to here into summaries and such. So, man, this has been a really fruitful conversation. I'm super appreciative. Um, I'm looking to see if there was any more comments that I missed. Nope, that's what we talked about. Yep, that's what we talked about there. That was okay. A lot of people had a lot of stuff to say in recommendation for. That's why I'm glad we went over it. Oh, David, the last meeting you had a question about non-SUDPs providing SUD assessments at non-BHAs. And I told you I wanted to get an answer to make sure there was no like waivers in place or laws or new nuances and anything like that. So I reached out to people within the HCA and the DOH, and basically there is a pathway. What I got told was there was a pathway for everybody to get the SUDP certification, which is like a lot less education requirements to become an SUDP. Basically, I can send you that information if you'd like. I can also put it in the chat for everybody. The WAC laws that stipulate that certification. If you wanted to become an SUDP, but you're like, let's say for instance, a doctor. There's a lot less hours required for training, and there's a lot less educational requirements too. Also, too, there's a chance that I'm being told that sometimes the education requirements you already have might meet the requirements of what you have to do. So it just depends on what they have. But I'll put the WAC in the chat so you can look at it. All right. Well, I pretty much recommendation 4 was the last thing, the one thing I really wanted to make sure to convey to you guys because I was presenting it and I was getting kind of I was like, man, what does this really mean? And now I think that we have a lot better picture on recommendation 4 on what we want to move forward with this. So, we have 5 minutes less, more or less. Is there anything that someone wants to bring up in the report that they really want to make sure that we discuss before we get off the phone here or the meeting? Okay. I just want to tell everybody thank you for showing up. All your voices are meaningful, and you guys gave just great feedback today and great comments in the chat and all this stuff. This has been a really productive meeting today, and I'm super appreciative of all of you being here. And thank you so much. And I hope you guys have the rest of your guys' good days and everything going. All right, I'll go ahead and give you back 5 minutes.